We've all heard those shocking stories about fit and healthy people who've suffered a sudden heart attack without any symptoms or any warning signs. And we're left wondering, how could this have happened? Well, scientists have discovered that the reason for this could possibly be another hidden cholesterol in our blood called lipoprotein A or LPA, which runs in families and which could possibly be the reason and increase our chances for an early heart attack or a stroke. Hello and welcome. I'm Dr. Elizabeth Thomas, and joining us live in this discussion today are two leading expert cardiologists from the Middle East and India, Dr. Hani Sabbour and Dr. Anil Dhall, who will share crucial information about this lipoprotein A, a cholesterol which you've probably not heard about, but testing for it could save your heart and your family's health as well. So before we begin, let's do a quick round of introductions. We are privileged to have with us Dr. Hani Sabbour, who is renowned in the field of cardiology in the Middle East. He is a Harvard-trained cardiologist with over 25 years of experience and is currently senior consultant cardiologist at the renowned Mediclinic Group in Abu Dhabi, UAE. He is American board certified in 6 specialties. He has co-authored the Middle East Dyslipidemia Guidelines and has conducted important research, including on LPA in the Middle East. Welcome, Dr. Hani, and thank you for joining us today.
Thank you, Dr. Elizabeth.
Anil Dhall, Director of Cardiovascular Sciences at Sarvodaya Hospital and Research Center, Faridabad. He is a renowned cardiologist with over 25 years of experience and is also a recipient of the Sena Medal, the prestigious Sena Medal from the President of India. Dr. Dhall has authored publications and has led cardiology programs across leading hospitals in Delhi. Welcome, Dr. Dhall, and thank you for joining us today as well.
Thank you, Elizabeth. It's nice to be here.
So, viewers, stay tuned for in the next 20 minutes, our experts are going to share with you 10 things that everyone must know about lipoprotein A. So let's begin. So let's start simple. Dr. Sabbour, could you explain in simple terms to our viewers what is lipoprotein A?
So thank you for the opportunity, and it's great to be with Professor Dhall as well as yourself. So I think one of the key points we have to remember is that bad cholesterol is the cause of all cardiovascular disease, and that's a key component. People have forgotten this. We focused a little bit on LDL for a long time. This is the bad cholesterol. But since the 1980s, we've known about this other bad cholesterol. I would call it a very bad cholesterol. Lipoprotein A contains the same protein that makes the bad cholesterol, but also contains these other tails, they're called Kringle repeats and ApoA, that makes it increase the inflammation in the blood vessels, more sticky and more likely to have blood clots. So it's a very dangerous part of LDL, but it's not present in everybody. We don't think that every human being has it, but at least 20% of people in our studies have this specific type of very bad cholesterol.
Thank you, Dr. Sabbour. So, so now we understood what lipoprotein A is, and I think we'd now like to know what happens to our heart if a person has high LPA levels. Dr. Dhall, would you like to take us through it? How does lipoprotein A affect our heart?
Just like Professor Sabbour described, you know, we've known about lipoprotein little a. We call it little a, just to be very clear. Since 1963, Keberg described this molecule as far back as 1963. So it's not like recent that we have discovered it. What we have also known is that it has tremendous amounts of properties which amplify the bad cholesterol or the LDL cholesterol, which Professor Sabbour mentioned. And this amplification is both in terms of atherogenesis, which means more plaque deposition or more cholesterol deposition in the vessels, and more thrombogenic, which means that it would probably also facilitate more clots actually happening. So there is also a component of inflammation that is being considered to be elevated with these patients, in the patients who have very high lipoprotein little a. Now, the problem is that we did not use it in our regular checkups for a long time, and therefore our intensification of our lipid-lowering strategies were confined to assessing the LDL levels. So, but once we actually know that the LDL level is getting remarkably amplified in a way that if you have, suppose, for example, somebody has an LDL level of, say, 80 or 100, but if he has a lipoprotein little a, which is very high, say in 100, this 100 LDL will probably be behaving like 200 or 250. I mean, please don't quote me, but this is just to get the implication of the amplification. Now, this can contribute to atherosclerotic cardiovascular disease, which means that blockages developing in your arteries, which can be arteries of the heart, arteries of the limbs, arteries supplying blood to the brain, and this is called as atherosclerotic cardiovascular disease. But we know that although these plaque depositions happen, it is acute heart attacks happen when clots develop. So therefore, these heart attacks will also be increased by, will also be amplified by lipoprotein little a. And for example, I'll tell you a small thing, that in the last few months or years, we have been kind of wary about prescribing aspirin as maybe a primary prevention for all. But the patients who have a high lipoprotein little a, I would definitely like them to take an aspirin. This also has relation to a narrowing of the major valve, which is the aortic valve. And in patients with aortic stenosis who are now being treated either surgically or being treated by transcatheter aortic valve replacement, we are finding that this may be one of the causal or at least an important factor, a contributing factor to the development of aortic stenosis. So if I have to summarize, atherosclerotic cardiovascular disease, which can be thrombotic, which can be atherogenic, which means more clots, more plaque. Clots in the heart, plaque in the heart, clots in the brain, plaque in the brain, clots in the leg, plaque in the leg, and also the aortic valve. So this risk of heart attack or heart disease increases almost by 2 to 4 times. I hope that gives you a perspective on what its importance is.
Absolutely. So this actually, what Doctor has said, has highlighted the critical importance of lipoprotein A, or LP little a, as it's commonly called, as you mentioned. So, so we know that this amplifies or increases our chances to have a heart attack or stroke over our risk caused by LDL and the other bad cholesterol. Dr. Sabbour, we know that LPA also has a family connection, a connection to family history. Could you elaborate on this?
So lipoprotein A is sort of genetically predetermined. Some people have none at all if you do the assay, and some people have a large amount. So this is definitely an inherited lipoprotein. It is probably the most common one, but as Professor mentioned, it's not being tested routinely by physicians, and they should. In fact, the European Society of Cardiology came up with a guideline about 1.5 years ago, recommending that at least once in a person's lifetime, a lipoprotein A has to be checked at least once because of the frequency that it's available. Now, the fact that it's genetic doesn't mean you have to do a genetic test to find it, right? You will find that in families, that have lipoprotein A, if you check the sons, the daughters, the aunts, the uncles, they will also have lipoprotein A. So if you do the lab test, it's sufficient if it's elevated above the certain threshold that is required, then you should test the entire family. This is called cascade screening. Now, the second way you have to deal with this is a much simpler test than doing genetics, is that it changes how you treat the patient. So if you have two patients with the same bad cholesterol, but one of them has a very high lipoprotein A, that's a much greater risk. And that patient needs to be treated aggressively to lower both of them at the same time. So there's a nice family tree that you've shown here, but I think the key component is you should test it in situations where you have a known history of high cholesterol in young people, if there's a known history of early heart disease, if at a screening, the first time you've had your bad cholesterol checked, lipoprotein A needs to be checked. And if that person has it, their kids and their family members need to be checked as well. This way we can identify families. As I mentioned from the research we did in the UAE, the prevalence is in the Gulf region, the prevalence is probably in the 20 to 25% range.
That was very,
yeah,
very
even in India, we have a prevalence of about 30%. And we understand that patients who have very strong family histories, when we look at their lipoprotein little a, we find that many of them have gross elevations of this small compound. And this particular lipoprotein little a probably acts as the game changer in these patients, because they may not have very great elevations of LDL. Their LDLs may be modest, but the amplification which comes because of the elevated lipoprotein little a can be causal and detrimental to their health.
Absolutely. So Dr. Sabbour had mentioned testing for it. Dr. Dhall, could you elaborate on how a person can find out their LPA levels? How do I find out?
It's a very simple blood test. I'm afraid I'm not a biochemist that I can tell you the mechanical, the actual details, but it's a very simple blood test. Your blood is drawn and the same is tested like a lipid panel. Now, we have had a lot of challenges. I mean, for the last 10, 15 years that I've been trying to get lipoprotein little a tested in India. You know, the problem comes because of the lack of awareness. And the problem comes because of not just the lack of awareness among physicians, among patients, but even if a patient goes with a prescription and with an advice to get this tested, the person who's sitting at the billing counter in a lab, I don't know how it works in the UAE, but in India, when he goes to a lab, the person sitting in the billing counter does not recognize this as something which is being done routinely. So he will either test for ApoA, which is an entirely different thing, or I'll find sometimes I get a report saying lipase levels so much. So, you know, we have to build awareness that this is another test which needs to be done. It's just like a blood test. It doesn't need any great preparations. It is, and Professor Sabbour pointed out that the European Society has actually mentioned that it should be done at least once in a lifetime. And that is because at least you know that there are amplifying factors working here. There are things which are going to amplify the LDL and things by which you know that you have to be a little more careful about this patient or this family in terms of both prescribing anti-lipid measures as well as in prescribing anti-thrombotic measures, which means either antiplatelets or blood thinners or whatever you may call it. But one of the other reasons why it has been mentioned one in a lifetime is still very, very recently, we did not have sufficient data from pharmaceutical compounds which could lower LP little a. So we were testing it once, and then we were focusing all our energies on reducing LDL because we believed that it acted through LDL in at least in atherogenesis. So therefore, it was said that it will be once in a lifetime. But as science has evolved, maybe this recommendation in the coming years will undergo a little change because we are now going to be on the threshold of having molecules which may be able to affect lipoprotein little a substantially, and we need to await their how it will affect the long-term clinical outcomes and how it will affect how it will make things better for patients.
So to put it plain and simple, this is a simple blood test like you do your other cholesterol blood test at a lab in your city.
It is just a simple blood test, just like a CBC, just like you're getting your sugar tested or your lipid level tested. You can get a simple blood test done, and that will tell you your lipoprotein little a.
Okay. Dr. Sabbour, so if we do the test, is there something like a normal range for people to know that if it's above this, it is high? What are the accepted normal levels for LPA?
So this has undergone some sort of evolution, and it comes from clinical studies, and it comes from data from large populations. We don't really know what's normal in our population. However, it seems that a cutoff point, which has changed now, and there's two different types of assay. One is measured in nanomoles, and one is measured in milligrams. I mean, regardless of that, it seems that to be healthy and not have cardiovascular disease, you should be less than 30 milligrams or less than 65 nanomoles per liter. Now, the reference ranges will change here and there, but in the most recent iteration of the guidelines, that's what's recommended for being displayed in the lab values. So don't be surprised if you do the lab test and you find that there is a different value, because they've been changing it and updating it. So if it's less than 30 milligrams per deciliter, you're basically not a high-risk patient. Above that, you're actually at significantly increased risk, even if your LDL appears to be in the normal range. And very high numbers means the risk goes up even more. Now, I actually have patients, and I'm sure Professor Anil has the same thing, where you have numbers in the 300s and 400s. These patients need a lot more attention and maybe searching for more treatments and really evaluating more effectively. The component of risk is there. It causes stroke, deposit in the carotid arteries. It causes heart attack because it hardens the coronary arteries. It narrows the aortic valve, which is something very specific to this particular lipoprotein, which we don't see as much with the typical LDL bad cholesterol. And it can cause pain in the legs and the arms because it can cause blockages in the legs. It's all over the vessels, and it's a very inflammatory and very aggressive marker. It's a sticky, inflammatory, atherogenic LDL protein that's even more active than the bad cholesterol.
That is a valid starting point for us. Dr. Dhall, so you had mentioned that this test is once in a lifetime because of the family history. You either have it or you don't. So it's enough if you check for LPA levels once in your lifetime. But who should be getting tested for LPA? Is there a specific criteria for everyone?
The European Society guidelines actually recommend that you should test this for everybody, because without, and especially people who come to us in the clinic whose risk we are evaluating, we should get a handle on what is going to be the risk over a period of time. And like I said, it's not only the LDL, so even people who have modest LDL. So obviously, evidently, anybody who has clinical features of like coronary artery disease, or somebody who has come with peripheral vascular disease or a stroke, or people who have aortic stenosis, we would definitely test. We would also test in their relatives, because we know that it is a heritable condition and it is genetically transmitted. So therefore, we should test in them, even in those who are asymptomatic. So that is why the general advice would be that we should be, and since we know that 20 to 30% of the population is going to carry this marker, or which is causal by itself. So there is a case for testing almost everyone. But those who come to us in the clinic and those who we are subjecting to tests to determine their risk, or we are trying to do risk mitigation, we should certainly add LP little a to the battery of other tests that we are doing.
Dr. Sabbour, I'm sure our viewers would like to know about the other bad cholesterol levels that we have, say LDL or VLDL. If those are normal, should I still be testing for LPA?
Yes, absolutely. So I think we sort of tried to make this point several times. First of all, the normal range for bad cholesterol or LDL depends on your risk itself. So if I have a patient who is 20 years old, doesn't smoke, perfectly healthy, no family history, no diabetes, no hypertension, then that patient can have an LDL of 2.56, like 100, and that's not a problem. I can then take the same LDL and have a patient who is 30 years old, smoker, hypertensive, high cholesterol, diabetes. That person is a very high risk patient, and that LDL is not acceptable at all, right? So remember, the way that the LDL is displayed in the lab doesn't fit how the guidelines and clinicians are looking at bad cholesterol today. Now, let's take that same patient and they have a bad cholesterol of 100, which is 2.56 or 2.6, right? Then I noticed that their lipoprotein A is 140. Okay. So that means not only do they have very high risk from their traditional risk factors and their blood pressure and so on, they also have now a fourfold multiple of high risk because of the lipoprotein A. So you have to look at it in context. It has to be analyzed by a physician. So a normal LDL really doesn't actually exist until you put it in the context of what the patient has. Now, if you add lipoprotein A to the equation, regardless of what the LDL is, it causes your risk to go up 4 times. And I think that's what people have to understand. It's a silent killer. It's not well understood by physicians. It's clearly not well tested frequently. And I think basically experts have to give this and patients have to start doing it more importantly. When you treat it early, it's critical. A genetically determined bad cholesterol starts from your day of birth. So even if you're 30 years old and you're completely thin and you're very healthy diet, if you have a very high LP little a, your risk of heart disease cannot be modified by your diet. It is produced by your cells, and it starts to accumulate in your blood vessels early. That's why we have such a large epidemic of young people having heart attacks and strokes in the Middle East, particularly in the practice I've seen. Patients even at the age of 20 years old are having heart attack. It's because of genetics. And that means you have an opportunity to treat early.
This is an interesting point that you raised. I think we're giving a very interesting and informative aspects about LPA because we are receiving some very interesting questions from the viewers. And one viewer has even asked, what kind of food items should such patients have and which ones to avoid? You just mentioned that it's not from the diet. Dr. Sabbour?
So one of the things to remember is that there is a misconception that cholesterol is purely from the diet. Triglycerides come from the diet. This is very important, okay? However, most of the LDL is produced endogenously. We call it endogenous biosynthesis, right? And genetically, people who have a deficiency of some of the LDL receptors, I don't want to go into the details, in the liver, will produce far too much LDL, and they have LDL levels of 4, 5, and 6. It's the same thing with lipoprotein A, right? You can't diet yourself to a safe level. Of course, if the enzyme is weak and the liver is not able to get rid of the bad cholesterol, using things that are high in saturated fats and fried and so on will clog up the system more. But to reach a safe level, you have to find a way to help the liver eject these bad proteins. These are literally toxins which the liver is designed to remove, but in patients with genetic disorders, they're not able to push that out because the enzyme is weak or slow.
So a related question from another viewer asked, lifestyle risk factors for lipoprotein A, which again was just answered by Doctor. So the same.
So must understand, there are no clinical signs or symptoms. You're not going to get, your doctor is not going to be able to examine you and suspect that you've got, only by history, he might be able to suspect if there's a family history, but he's not going to be able to get a physical sign which is going to make him suspect that you've got this disease. Secondly, even for the LDL cholesterol, just like Professor Sabbour said, we have got this, patients come to us and they tell us that, oh, I've got elevated LDL cholesterol. Don't worry, doctor. I will fix it by my lifestyle and diet. And actually, we have also misled a lot of people over the last couple of decades by telling people that these inherently cardiovascular diseases are only lifestyle diseases. So, well, your diet contributes to only maybe 1/3 to 1/4 of your cholesterol. The rest of the cholesterol is being endogenously synthesized. So if that is being synthesized from the body itself, how will your dietary modification really help? It can help. You can't challenge God and nature. So you can't say that because, well, since it's all going to be done endogenously, I can eat whatever I want. No, we are not going to advise people to challenge God and nature and eat a lot of red meats and eat everything and anything, but in moderation, with our understanding that some precautions are necessary. We are not challenging God and nature. We are not challenging the pre-existing concept, but at the same time, we realize that we probably need agents to understand how much of LDL reduction we are going to be able to do. And that is where pharmaceuticals or pharmacological agents come in. And we have very good data now that we have achieved a lot of good with the currently available pharmaceutical agents. However, there is still a residual unmet need. And that residual unmet need may actually be mitigated once we have agents and good agents which can successfully also lower the lipoprotein little a. So right now, what we do in patients who have elevated lipoprotein little a, we target lower LDL goals. And I know this nausea about whether we are treating risks or we are treating numbers has been doing the rounds for the last couple of decades, and every time there are new guidelines, this kind of changes. But please understand, patient is a whole. So there are critical numbers, but also you have to determine, just like Professor Sabbour said, if he's a smoker, he's diabetic, he's got strong family history, well, you need to be much more on your feet and much more proactive. So the paradigm in treating atherosclerotic cardiovascular disease has actually moved from being reactive to symptoms, from being reactive to physical signs, to being a little more proactive so that we can prevent these diseases outright.
Absolutely, Dr. Dhall. I think this is also new information for our viewers that only 1/3 of our cholesterol is from the diet, as both our experts had highlighted. We also have another interesting question. If we don't have a family history of cardiovascular issues, do we need to worry about LPA, or should we still get a blood test done to be safe?
It
Dr.
appears
Sabbour?
that when we say that between 25 to 30% of the population in our region has high lipoprotein A, that means you wouldn't know that unless you do the test, right? So obviously, the highest risk are patients with a family history of an early heart attack, an early stroke, or vascular disease. But because our population in the Middle East and I think in India are younger, it's always important to test early, because if you test early, you can catch that train before it leaves the station, as it were. So I think that's the key point. It's a very simple test, and it will advise you as to how the genetics and the function of your whole cholesterol lowering and excreting system is working at the stage that you can prevent a heart attack rather than wait for a heart attack.
Absolutely. Which also brings me to the question of how common is high LPA levels, Dr. Dhall? Is it commonly seen in India? Is it comparable to the rest of the world?
There are differences in different parts of the world, in different populations. There are differences, and we are getting our act together, and prevalence data is being worked out. Like Professor Sabbour said, that there are two different, you can either measure it in the molar equation or in the milligram equation, and therefore people are in most regions are getting this much under control. They are realizing that in different populations you would have a different prevalence of lipoprotein little a in every region with every genetic background. It needs to be understood. We in India have, we always say that we are the world capital of heart disease. And we know that till now, our refrain used to be that we would talk about atherogenic dyslipidemia as meaning people who have metabolic syndrome, modest LDL, high triglycerides. And we used to think that we get such aggressive disease. But now that we are testing for lipoprotein little a, we realize that in over 30%, which means every third person who is sitting in a room, if there are 3 people sitting in a room, is likely to have high lipoprotein little a. So which is a lot. And this shared ancestry actually tells us that since it's so prevalent, this is where our entire LDL-centric hypothesis needs to be further reinforced to the extent that we need to be able to bring down the LDL in these patients even more energetically than we would do if the LPA was normal. So we need to identify these people. We need to identify these people well in advance because, as Professor Brunwald says, if you want to live to be 100, you have to keep your LDL as low as possible for as long as possible. But apart from LDL, we should also look at lipoprotein little a, because if you want an elevated lipoprotein little a, then you need to keep your LDL even lower. So there were a lot of myths and misgivings among people as to how much of lipoprotein LDL can we go down to. Well, we have sufficient data. Just as an anecdote, you would know that the cord blood does not have more than 25 milligrams percent of LDL cholesterol, which means that that is the amount of LDL cholesterol required for your brain to actually originate, and that was fine. Then if that was good enough, then why are we worried about a lot of cognitive defects that we talk about when we are using agents, and the newer agents are even without these cognitive dysfunction effects. So the naysayers who have had their say in this world have talked about the various bad things which you do when you lower LDL cholesterol. But actually, we need to understand that there was a trial with a drug which is called the Ebbinghaus sub-study of the Fourier trial, where they took the LDL cholesterols down to 20. And that is also did not produce cognitive dysfunction. So who are these patients where we are going to do this? Are patients who are going to have a very high LP little a. We are going to be, because right now, we don't have the agents to reduce LP little a. We are doing a couple of trials. We are also involved in a couple of those trials. We are getting LPA down, but we also need to translate it into clinical benefit. And we need to translate it into outcome analysis, and we need to demonstrate safety. So it's a little time away for the introduction of those drugs. But right now, we are focusing on measuring LP little a to identify how aggressively we will attack LDL.
Yes, absolutely, Dr. Dhall. So that answers a question of if we have high LPA levels, how would it be addressed at this point in time? That was what Dr. Dhall had explained. Dr. Sabbour, people may ask, I'm still in my 20s or I'm still in my 30s. Is there any benefit in knowing my LPA level early? And what should a person with high LPA level, let's say he has taken the test, what should he do to stay healthy?
So I think we need to think about it in a different way. Familial hypercholesterolemia is a less common type of high cholesterol that starts since birth. And it can be moderate, it can be severe. That means you can have children with an LDL of 300, which is like 7 in the millimoles. This type, lipoprotein A, is also familial, as I mentioned. It is determined since birth. It's actually much more common than true familial hyperlipidemia. And it has a direct impact on all sorts of heart disease and vascular disease and stroke. So the focus in the past has been on things that we can treat aggressively, and that is the bad cholesterol, LDL. If you have familial high cholesterol, either with very high LDL or high lipoprotein A, you are looking at a marker of progressive heart disease. And therefore, the treatment becomes very important. What is the current treatment in this era? As Professor mentioned, there are treatments that are coming specifically to LPA, but if you have a high LPA and you have a high LDL, that's what we need to focus on. We lower the LDL more aggressively. So just to be more concrete on the example, say I have an LDL of 100 and I have a lipoprotein A of more than 30. Let's put a number like 60. That means I have become a very high-risk patient because of the presence of lipoprotein A, because I now have a genetically predetermined high cholesterol. And here I'm going to target lower my LDL to be safe, less than 1.4, okay, which means 55. Can I do that with diet and exercise? It's practically impossible. You can maybe with a very aggressive, strict diet, if you're vegan maybe, and you do intermittent fasting, get down to 78. So now you are telling yourself, and the doctor is telling you, you need to be on a treatment that lowers the LDL aggressively. We also know that the new generation of cholesterol medications that are given as an injection can lower your bad cholesterol by an additional 50% and lower the lipoprotein A anything between 19 and 20% as much. So I've had patients where we've applied these injectable cholesterol medications on top of a statin and diet, and we get the LDL to very low numbers, 20, 15. And we bring the lipoprotein A again down by about 20%. So that's the standard of care right now. But yes, absolutely. We do have treatments, and the treatments are directed to correct the genetic abnormality or correct its effects in terms of the bad cholesterol and the lipoprotein A together.
Thank you, doctor. That was very insightful. So we do have some more viewer questions, but it's again related to the diet, so we won't be taking that. What should I eat in daily life? I think doctor has already addressed those questions. We have a patient a viewer who asks, as a patient, what do I do if my LPA is high? Again, it's been addressed in our discussion. My father died from a heart attack at the age of 50, but my cholesterol level was normal in my blood test. Should I check LPA level also? I think this has also been addressed, but Dr. Dhall, would you like to add your comment to that?
I certainly, when I advise a lipid panel, I almost always ask at least once. I check if I have previously done a lipoprotein little a, in which case I don't repeat it. But unless the patient is on inclisiran, which is because it's a little expensive drug, so we are not using it very freely. But most of the time when we do lipid panels, we would also check for lipoprotein A at least once in a person's lifetime to assess the risk. And we know, since it is heritable, we would also check it in people, if the kids are 13 and 17. I don't have a problem. We are seeing some little bit of gender signals. We find that women who have atherosclerotic cardiovascular disease also tend to have much higher lipoprotein little a. So we are looking at all of this. I think much of what we are doing is going to cause more learning in times to come. We are going to have some more viable conclusions. But suffice to say, it is important to recognize it. It is important to measure it. It is important to amplify our effort to contain the scourge of atherosclerotic cardiovascular disease.
So we've had a good insight into the critical importance of LPA and how important it is to get tested. So the bottom line message for our viewers is, regardless of your age, and if you have family history, get tested, speak to your doctor and get tested for LPA at the earliest, which is why we at DocFlick are running a campaign for this World Heart Day, which falls on the 29th of September. And please follow our page for more updates on lipoprotein A. And our initiatives will be on our page to highlight the importance of this critical cholesterol that not many know about, but should be testing for. Now, before we end the session, I'd like to ask one question to both our experts. And I'm sure that this question is in the mind of every one of us who uses social media regularly. So we see a lot of false claims and fake information on the internet saying that, cholesterol is good for us, it's not harmful, we don't need medication, fats are good, and so on. Is there any truth in this? Dr. Sabbour, would you like to address this question?
Thank you for bringing this up. This is a huge public health hazard. This is very similar to the stuff that was being promoted at the beginning of COVID, which is extremely hazardous. Cholesterol is a byproduct. LDL is designed to be excreted. It is a carrier molecule, and the liver has a huge amount of power to help patients get rid of it. But the problem is there are people on the internet who talk about cholesterol being healthy. Good cholesterol has been shown to increase slightly with exercise, but can never come to the point of counteracting the very bad effects of bad cholesterol. That's the bottom line. And, there have been decades of research on increasing good cholesterol with medications and other things. You cannot combat heart disease this way. But what's been very successful over the last 40 years is lowering the LDL. Every 1 millimole reduction of LDL reduces heart attack and stroke by 22% over the next 5 years. And when you leave it to go up, it increases by 22%. It's a simple line, linear relationship. It's just math. So it's incredibly dangerous when people talk about these natural remedies and herbs and all of this other stuff that literally does nothing for the patients, right? So I will tell you that it's very unfortunate, but worldwide, 90% of people who've had a heart attack are not achieving the low cholesterol levels that they need to prevent a second and third heart attack. 90%. And I strongly believe that it's this fake media, the incorrect information promoted by non-physicians or even physicians with bad intentions for the purpose of promoting vitamins and herbs and minerals, which really have no scientific evidence. So please beware of this. Cholesterol, LDL, is a toxin, and the entire science shows that it has to be reduced, and removed.
Dr. Dhall, you look eager to add in your thoughts as
No,
well.
I'm
Please
just
share.
amused by Professor Sabbour's mentioning that these are bad intentions. I don't believe that they're always uniformly bad intentions. I think it is lack of understanding. I think we need to generate appropriate understanding. Let me tell you some things, lessons from history. So in about 1918, 13 or 18, the Surgeon General of the Russian army was a guy called Nikolai Anichkov. And what he did was he took some rabbits and he fed them enormous amounts of egg yellow, enormous amounts. Now obviously this kind of cholesterol hyperload could not be handled by these poor rabbits who eventually some of them succumbed, and some of them because their individual cholesterol levels went up to about 1,000 milligram%. I mean, this was a huge overload. Then he sacrificed these animals, and he found that many of their vessels were choked with a lipid waxy substance, and therefore started what is called the lipid hypothesis. The lipid hypothesis is that this substance gets deposited into the arteries and can cause blockages. And these blockages can sometimes occlude the vessel by interaction with some blood components like platelets and clotting factors, and can cause clots because the arteries are narrow. Some of the narrow arteries, I liken them to a volcano. I liken them to a single fried egg. And if you see a single fried egg, imagine a single fried egg being wrapped on the inside of a tube, which is your artery. And a little abrasion, and what happens to the single fried egg? The yellow bursts, and that attracts platelets, and that forms clots. So we kept trying to see if this is from the diet, how do we reduce it? So we tried many things. People tried dietary measures. People tried using bile acid resins. People tried everything. But what is important to understand is that this LDL cholesterol, which is being measured, has actually a receptor on the liver. And I normally give an analogy that this receptor is something like this, it's on surface of the liver. And this takes in the LDL cholesterol. And this LDL cholesterol, it is the circulating LDL cholesterol, which is actually bad for us. And once it takes in this LDL cholesterol, the LDL cholesterol gets excreted, just like Professor Sabbour said. Now, in fact, in 1984, Goldstein and Brown awarded the Nobel Prize for elucidating the structure of the LDL receptor. So what we need to know is that the diet is maybe going to give a load. So when we eat food, the large gut absorbs these chylomicrons, they circulate, and a large amount of them are cleared by the liver. But because they're not, when these receptors which are acting on the surface of the liver, they have to push this cholesterol inside. Now, if it is not pushed inside, if it remains circulating, it places us at a risk. And therefore, we had to develop drugs which will combat it. Now, some of that studies came from understanding the simple things. The red yeast rice, in a way, has something called a statin. And it was Akiro Endo who discovered the statins were effective in addressing the rate-limiting step of cholesterol biosynthesis. This may sound a little too fancy biochemistry, but when you do this, the receptors don't regulate, upregulate or downregulate. And so you could successfully lower it. But beyond that, we still have unmet needs. So statins have become established standard of care in primary, secondary, and tertiary prevention of atherosclerotic cardiovascular disease. But we still have unmet needs. And for that unmet need, we need to realize that we have now things like lipoprotein(a). So coming back to the question, so many Dr. Google schools and WhatsApp universities tell you that cholesterol's off the naughty list. The American Heart Association has validated that it is off the naughty list. Eat your red meats, eat a lot of... You can't challenge God and nature. You can't challenge and overload your system. So you do that in moderation, we don't have a problem. You do that without stressing the system, you don't have a problem. But cholesterol is important. Just like an infection, we have to prove that in an infection, so we have something called Cox postulates. And the LDL is actually present in the plaque, in the waxy plaque that is there. So the oxidized LDL is actually present. So we need to address cholesterol. We need to lower LDL. We need to look at some of the unmet needs which are arising from lipoprotein(a). And so, guys, don't believe everything that's thrown at you from the internet. Evaluate it for yourself. Consult your physician. Understand that things have not become standard of care without detailed studies and without real, shall I say, research into the safety, the efficacy, and also the cost effectiveness of therapies. So we have now had good experience of almost 3.5 decades of using statins, which is very good, but there are unmet needs which are being met by newer molecules. There is a lot of research going on. There are going to be some transformational technologies. We now address things by putting antibodies. So the breakdown of the LDL receptor happens through something called PCSK9. We have antibodies which block PCSK9. So there are PCSK9 inhibitors, which have other drugs which are small interfering RNAs. I don't want to take you through all of that, but there is a great, shall I say, landscape which is opening. And hopefully with all of this, we will be able to transform the bad effects of having elevated cholesterol and the huge amount of disease burden that we carry. So play safe, look out for yourselves, look out for your families, check your LP(a), and beware of social media.
So viewers, you heard it right here from the experts. We've had a good look at lipoprotein(a). It is a bad cholesterol hidden in your blood. It is connected to family history, but everybody needs to get tested for it. It's a simple blood test at any lab near you. Speak to your doctor today and get tested for LPA, and do not be carried away by fake news on social media. Take control of your heart's health. It's in your hands. Thank you once again, Dr. Sabbour and Dr. Dhall, for joining us today, despite your busy schedule from your practice, to share such important information in public interest. Viewers, that's all we have time for today. Thank you all for joining in. Stay safe, take care, and have a beautiful day.